Right. So a very good evening, everyone. Okay. So am I audible to everyone? Yes. Jane, hello. Very good. So let us start with the image-based questions on endocrinology. So before starting this session, let me just introduce myself. So I am myself Dr. Rajesh Guba, and I am the general medicine educator on Arise Medical Academy. All right. And so I have started with the series of the image-based questions on the individual topics related to the general medicine, right? So as a part of the series, today I have started with the endocrinology image-based questions. And this particular image-based questions, I will be coming live every day at 10:30 p.m. Right? So 10:30 p.m. you can see me live, and I will discuss many and many image-based questions. Right. Now let us start with the first question. Yes. So you see the first question. The sign elicited as shown in photograph indicates hypercalcemia, hypocalcemia, hypernatremia, hyponatremia. So what is this particular sign which is being elicited? Is it seen in hypernatremia? Is it seen in hypocalcemia? Is it seen in hypernatremia, or is it seen in hyponatremia? Yes, any one of you? Yes, Sarkar, good evening. I'm fine. Thank you very much. Soumya, okay, first of all, what is this particular sign? Very good, Sarkar. So we have the answer from Sarkar, that is hypocalcemia. Now, first of all, let me explain you what is this particular sign. So this is nothing but the Chopstick sign. Right? This is nothing but the Chopstick sign. So, like, how do you do this particular Chopstick sign? I'll explain you the Chopstick sign, right? So I hope many of the students who have attended my endocrinology sessions recently are watching these sessions, if I'm not wrong. Now, this Chopstick sign is seen in patients with the hypoparathyroidism. Right? It is seen in patients with the hypoparathyroidism. Now, what is this particular Chopstick sign, first of all? If you take this Chopstick sign is, how do you elicit this? On tapping the facial nerve at the angle of the mandible. Right? Tapping the facial nerve at the angle of the mandible, that will cause contraction of the facial muscles, right? Contraction of the facial muscles on that half, right? Contraction of the facial muscles on that half of the face. Okay, so this is what is called as the Chopstick sign. And where do you see this particular Chopstick sign? You will see that in patients with the hypoparathyroidism, right? And in hypoparathyroidism, what is that you will have? You will have the presence of the hypocalcemia, right? So Yeah, that contraction of the facial muscles is nothing but your facial grimacing. It is nothing but your facial grimacing. Okay, right. Now, can anyone tell me what is the other sign what you will see in patients with hypocalcemia? Yes, any one of you? What is the other sign that can be seen in patients with hypoparathyroidism apart from this particular, the Chostek sign? Right? Let me tell you that. So the other sign, what you see is very important, that is the trojan sign. Very good, my foos. Right? That is nothing but the trojan sign. So trojan sign and as well as the Chostek sign. These are the two signs what you will see in patients with the hypoparathyroidism. Right? These are the two signs like what you will see in patients with the hypoparathyroidism. Now, let me tell you how do you elicit this particular trojan sign. And in the entire medicine, we have three places where you have this trojan. I'll show you all. Now you take this particular trojan sign. What you need to do? You need to apply the BP cuff. Okay? And you have to inflate it. How much you have to inflate? You have to inflate to 20 millimeters of mercury above the systolic blood pressure. And that particular hand is occluded for nearly around 3 to 5 minutes. Okay, that arterial blood flow is occluded for nearly around 3 to 5 minutes. And what is that you will observe? You will observe the presence of or the appearance of carpopedal spasm. Right, you will observe the appearance of the carpopedal spasm. Okay, so I'll repeat the point again. So how do you elicit the trojan sign? Trojan sign, it is elicited in patients with hypoparathyroidism with hypocalcemia. So here the BP cuff, it is applied or it is inflated. How much it is inflated? 20 millimeters of mercury above the systolic blood pressure. And you have to inflate the BP cuff above the systolic blood pressure by 20 millimeters of mercury, and you have to occlude the blood vessel for nearly around 3 to 5 minutes. And after 3 to 5 minutes, you will notice the appearance of this particular carpopedal spasm. Right? You will notice the appearance of this carpopedal spasm. That is what is called as the trojan sign. That is what is called as trojan sign. Now, let me tell you, we have another important sign called as the trojan's lymph node. Right? Trojan's lymph node. I will tell you where you will see that. And you also have what is called trojan's sign of malignancy. So three important trojans, let me explain you. Right? Three important trojans, let me explain you. Okay. So this is your trojan sign. Now let me show you the trojan's lymph node. Now this is your trojan's lymph node. So what is this trojan's lymph node? It is seen in patients with the malignancy of stomach. So in malignancy of stomach, there will be metastasis from malignancy of the stomach to the left supraclavicular lymph node. Right, to left supraclavicular lymph node. And this left supraclavicular lymph node where the metastasis has occurred, that is nothing but this lymph node. This lymph node, it is also called as right. This is also called as the virtuous lymph node. Okay, right. So this is another word, trojans in the medicine. One is your trojan sign that is seen in patients with hypoparathyroidism. This is your trojan sign seen in patients with the malignancy of the stomach. Right, seen in patients with the malignancy of the stomach. Now, I will just show you one more trousers. I'll just show you one more trousers. Now, what is that another trousers? That is called as the trouser syndrome. That is called as the trouser syndrome. Now, what is this particular Trojan's syndrome? Trojan's syndrome, right? You can see this is a lower limb, right? Where you can appreciate the redness of this particular vein. You see, this is the redness. Whatever you are observing is the redness of this particular vein. That is called as phlebitis. That is migratory phlebitis. Migratory thrombophlebitis. Okay, and where do you see this particular Trojan syndrome? We see Trojan syndrome in case of the pancreatic cancer. Right, in case of the pancreatic cancer. Yes, Avinash. Good evening, Avinash. How are you? I'm fine. Thank you very much. Right. So these three Trojans you should not miss. Okay. One is your Trojan's sign seen in patients with hypoparathyroidism. The other Trojan's sign is nothing but your virtuous lymph node, where it appears due to malignancy of the stomach, which will metastasize to the left supraclavicular lymph node. And the third one is the Trojan syndrome. Trojan syndrome is nothing but seen in patients with the pancreatic cancer. That is nothing but the migratory thrombophlebitis. Okay, right. So this completes the discussion of the Trojan's sign. And actually, the question was on the Chostek sign. The question was on the Chostek sign. Okay. This was the question. Sign elicited as shown in photograph indicates what? It indicates the hypocalcemia. Now, we will move on to the next image-based question. Yes. Yeah. Yes, Bhagyashree. All the three, they have more or less same spelling, except for the Trojan sign of the virtuous lymph node. The Trojan sign that has the different spelling, but Trojan syndrome and Trojan sign of hypoparathyroidism, they have same spelling. Okay, right. Now see the next important question. We have a 42-year-old man shown here, presents with fatigue and muscle weakness. This patient also may have all of the following features except thin, friable skin, hypertension, weight loss, acne, centripetal fat distribution. Right. So who has answered this question is Avinash has answered, and Shama. Shama, another student who has answered. So whoever has answered C, that is correct. Okay. Right. So first of all, you should know what is the diagnosis. Can anyone tell me what is the diagnosis? What is the diagnosis? The diagnosis is Cushing syndrome. Diagnosis is Cushing syndrome. So how are you able to make out? Yeah. How are you able to make out that it is the Cushing syndrome? Now you see these are the purple striae. Right, these are the presence of the purple striae, right? And in the presence of this particular purple striae, what is the other features the patient has? Fatigue, muscle weakness. So these features you will have in the Cushing syndrome, right? Now, can anyone tell me, right? Yes, can anyone tell me which muscle weakness will be there in these individuals? Yes, which muscle weakness will be there in these patients with Cushing syndrome? Any one of you? Right. So these patients, they will have proximal muscle weakness. Right? They will have proximal muscle weakness. Very good, Vishnupriya. It is your proximal muscle weakness what these individuals will have. Right? Good. Next. Then followed by that, you take the dermatological manifestations. they will have this thin friable skin. Now, can anyone tell me why they will have this thin friable skin? Yes, any one of you? Why do they have this thin friable skin? They will have the thin friable skin because of degeneration of stratum corneum. This is what the answer I want, right? This is due to degeneration of stratum corneum of epidermis. Okay, right. Yes. Now, these patients with the Cushing syndrome, they have hypertension. Now, can anyone explain me why they have hypertension in these individuals? Yes, can anyone explain why there will be hypertension in patients with the Cushing syndrome? Why there will be hypertension in patients with the Cushing syndrome? Any one of you? Why? Because in Cushing syndrome, yes, anyone? Why there will be hypertension in these patients? Very good. So hypertension, why? Because of, not because of increase in catecholamines, that is because of increase in the sensitivity of the catecholamines, right? Increase in the sensitivity of catecholamines. That is the reason why these individuals will have the hypertension, increase in the sensitivity of the catecholamines. See, what do you understand by this word increase in sensitivity? It is very simple. What the steroids will do is, steroids, they will upregulate the alpha receptors, right? They will upregulate the alpha receptors on the blood vessels. And that is the reason why they will have hypertension. There will be upregulation of the alpha receptors on the blood vessels, and that is the reason why they will have hypertension in these individuals. Now, coming to acne, right? Coming to acne. So, if you take this particular acne, it is seen only in females with Cushing's, right? Only in females with Cushing's, they will have this particular acne. Okay, right. And then followed by that, but what is the other option? What is actually the answer? The question asked is except. What they will not have? They will not have weight loss. What they will have is weight gain. Right? What they will have is weight gain. Right? They will not have weight loss. And centripetal fat distribution will be there. That is secondary to lipolysis. That is secondary to lipolysis. So what will happen in Cushing's? There will be excessive lipolysis, and the free fatty acids, right? The free fatty acids, they come and get accumulated within the abdominal area. Right? The free fatty acids, they come and get accumulated gets accumulated within the abdominal area, and that makes the individual to develop what is called centripetal obesity. Centripetal obesity. So this is about the features of the Cushing syndrome. Yeah. So because of the redistribution of the fat, let me tell you. Right. So there will be lipolysis in Cushing's, and there will be excessive release of the free fatty acids. And these free fatty acids, they will go and gets accumulated in the nape of the neck. Right? They will go and get accumulated within the nape of the neck. And that will result in what is called buffalo hump. That will result in what is called buffalo hump. Okay, that is one thing. And these free fatty acids will go and get accumulated within the abdominal area, resulting in truncal obesity. right? And these free fatty acids will also go and get accumulated within the face, and that will result in moon-shaped face. Right, that will result in the moon-shaped face. Okay, right. So this is what is the question related to Cushing syndrome. Hmm? So only very few students were able to answer this, but this is a very important question. They will not have weight loss. What they will have is weight gain. So please remember this very important question related to be able to recognize that this is Cushing's based on this purple striae. Now, why do they have this purple striae is another important question. Why do they have this purple striae? That is due to excessive stretch of the skin. Right, that is due to excessive stretch of the skin. That is the reason why these individuals will have the purple striae. Okay, right. Now we will move on to the next question now. Yes, another very interesting question. Okay, so this is how the images will be asked in your exams. You should be prepared. You should be prepared with any sort of image-based questions. And nowadays, the image-based questions, they have become very popular in your entrance exams. And in the recent FMGE exam also, if you see, there were nearly around 70 to 80 image-based questions. So you should not neglect these image-based questions at all. Right. Now, you see the next question. Heart defect most commonly associated with the syndrome which is given to you. Atrial septal defect, patent ductus arteriosus, coarctation of aorta, ventricular septal defect. So first of all, you should know coarctation of aorta. Okay. Okay. So yes, Avinash, can you tell me what is the diagnosis of that particular image which is given to you? That chromosomal analysis. Please just tell me based on the chromosomal analysis, what is the syndrome there? Okay, so Avinash said coarctation of aorta, Shama, atrial septal defect, then we have ventricular septal defect. So Y is absent. So what is this now? It is 45X0. So what is 45X0? Very good, Shama. So 45X0, it is your Turner syndrome. Right, 45X0, it is your Turner syndrome. Okay, now in case of or in the Turner syndrome, what is the most common associated heart defect? What is the most common associated heart defect? Right. So let me just show you what are all the various cardiac defects you will come across in patients with the Turner syndrome. See, in Turner syndrome, ventricular septal defect is most common. Right, ventricular septal defect is most common. Okay, now apart from the ventricular septal defect, the other abnormalities what you will see in the Turner syndrome. One is your VSD. No doubt in that VSD is more common. And what are the other heart defects associated in the Turner syndrome? Very good, Avinash. So it can be associated with coarctation of aorta and as well as the bicuspid aortic valve. Right. So there are in Turner syndrome, there are three congenital heart diseases which can be seen. One, VSD. Two, coarctation of aorta. Three, bicuspid aortic valve. Right? right? 3 is your bicuspid aortic valve. These three are common, but among all these, which is more common again? Okay, among all these, the ventricular septal defect is more common, right? Among all these three, the ventricular septal defect is more common. So that you should be able to make out. Okay, right. Now we will move on to the next question. So this is not a question related to your, yes. Huh. Now answer this. You watch the child properly, observe him properly, and then try and correlate with the options which are given to you. Physical condition of the child shown in photograph is seen in adrenal insufficiency, pseudo-hypoparathyroidism, Prader-Willi syndrome, Soto syndrome. Very good, Avinash. So this is a patient with the Prader-Willi syndrome. This is a patient with Prader-Willi syndrome. Very good, Vaibhav. So now I will take up everything. Okay. Now you take this adrenal insufficiency. Adrenal insufficiency, right? What is that? It is your Addison's. So in Addison's, what they usually present with? In Addison's, they usually present with weight loss. They usually present with weight loss, but not weight gain. And not only that, in these patients with the Addison's, they will also have the hyperpigmented skin. But if you take the child there, so how is the skin of this child? Right, it is completely a fair white skin. It's a fair white skin. So your Addison's or adrenal insufficiency, it is completely ruled out. There should be weight loss, but how is the child? The child is obese. The child is obese. So that is the reason why. Your adrenal insufficiency cannot be considered at all in this patient. Now, you take the second option, that is pseudo-hypoparathyroidism. Now, regarding the pseudo-hypoparathyroidism also, we have one image-based question. Pseudo-hypoparathyroidism means what? Pseudo-hypoparathyroidism means there is resistance to the parathormone. Actually, why is it called pseudo? Why? Because parathormone levels, they are not reduced. Parathormone levels, they are not reduced. Okay. So here, parathormone levels, they are present in adequate quantities. Right? Parathormone levels, they are present in adequate quantities. But there is resistance to the action of the parathormone. Right? There is resistance to the action of parathormone. Okay. Now we have a clinical entity called as pseudo-hypoparathyroidism type 1A. Right? Pseudo-hypoparathyroidism type 1A. Now, can anyone tell me what is this pseudo-hypoparathyroidism type 1A? Can anyone tell me what is this pseudo-hypoparathyroidism type 1A? Because there is an important image-based question related to that particular pseudo-hypoparathyroidism type 1A. Can anyone tell me, please? Right. So let me tell you. So we have a syndrome called as Albright hereditary osteodystrophy. Right, Albright hereditary osteodystrophy. Okay, now what is this Albright hereditary osteodystrophy? Right, so the important image based question what you have regarding this is, yes, can anyone tell me what will be the abnormality of the hand in these individuals with Albright hereditary osteodystrophy? Yes, can anyone tell me what will be the abnormality in the hand of a patient with Albright hereditary osteodystrophy? I will show you that image, and that can be asked as an image based question related to that pseudo hypoparathyroidism type 1A. Right, so let me show you that image. I'm not getting the answer from any one of you. Very good, Avinash. So that is called as knuckle knuckle dimple dimple sign, where you have short fourth and fifth metacarpal bones. Okay, where you have short fourth and fifth metacarpal bones. Okay, so this is what is called as, now when these individuals, okay, so they have short fourth and fifth metacarpals, right, that is one point. And when these individuals, whenever they make a fist, there will be, right, there will be formation of a knuckle and as well as a dimple. So this is what is called as knuckle knuckle dimple dimple sign. Right, knuckle knuckle dimple dimple sign. Now see what will be the feature. So dimple dimple sign. So what is this now? It is your pseudo hypoparathyroidism type 1A. Actually, you have totally 4 types in that. So this comes under your pseudo hypoparathyroidism type 1A. Now, what are the other features? It Albright hereditary osteodystrophy. Number one, definitely yes, you have the presence of brachydactyly. You have the presence of brachydactyly. Now, apart from brachydactyly, what are the other features in Albright hereditary osteodystrophy? The other features of Albright hereditary osteodystrophy are hypogonadism, right? Brachydactyly syndrome, choroid plexus calcification, right? Where will be your choroid plexus? The choroid plexus will be in the ventricles of the brain, right? In ventricles of the brain. And these choroid plexus are the one which are useful for the production of the CSF also. Okay, right. And there will be also hyperplasia of dental enamel. There will be full cheeks and hypocalcemic tetany. Right? Why there will be hypocalcemia? Why? Because there will be pseudo hypoparathyroidism. Right? Why? Because there will be pseudo hypoparathyroidism. That is what you will see in the Albright hereditary osteodystrophy, hypogonadism, brachydactyly syndrome, choroid plexus calcification, hypoplasia of dental enamel, full cheeks, hypocalcemic tetany. Right? So these are about the features of the Albright hereditary osteodystrophy. But what is actually our question? Our question was on the Prader-Willi syndrome, right? Now, can anyone tell me what is the chromosomal, what is the chromosomal abnormality you will see in the Prader-Willi syndrome? Any one of you? Yes. Which chromosomal abnormality you will see in the Prader-Willi syndrome? Definitely yes, they are obese and they are prone for development of diabetes mellitus also. But can anyone tell me what is the chromosomal abnormality associated with this? Very good, Avinash. Excellent, Avinash. Right. So the chromosomal abnormality, what you will see is on chromosome 15. Right, on chromosome 15. Okay. And these patients, they will have muscle weakness. They'll have poor feeding and they'll also have a very slow development. Right. They'll also have very slow development. Okay. So this is about your Prader-Willi syndrome, which is a genetic disorder. And these patients, they are obese and they also develop what is called type 2 diabetes mellitus. Okay, so these patients, they are constantly very hungry. Constantly they are very hungry. Okay, and because of this excessive hunger, that will lead to obesity, and this obesity will lead to type 2 diabetes mellitus. Because obesity, it is the risk factor. It's a very important risk factor for the development of type 2 diabetes mellitus. For the development of type 2 diabetes mellitus. Okay, right. Now we have one more option in that question. Right. So what is that another option in the question? That is your Soto syndrome. That is your Soto syndrome. Now let me explain you what is this particular Soto syndrome now. This Soto syndrome is also a very important image-based question. And let me just show you how does an individual with Soto syndrome appear. So they have that characteristic distinctive facial appearance. Now what is that distinctive facial appearance? They will have a very long narrow face. You see here how is the face of the child, right? So a very long narrow face. Okay, you see this. The child has a long narrow face. And how is the forehead of the child? Right, so the forehead, it is very high. Right, the forehead, it is very prominent. Okay, and how is the cheeks of these individuals? The cheeks, right, they are flushed, red cheeks. Okay, and you take the chin of these individuals, they have a pointed chin. Pointed chin. So this is what is called as the Soto syndrome. Okay, so Soto syndrome, it is a disorder characterized by distinctive facial appearance. There is overgrowth in the child and learning disabilities are there, and there is delayed development of mental and as well as the movement abilities. And the characteristic appearance of the child in Soto syndrome, they'll have a long, narrow face, they'll have prominent forehead, flushed cheeks, they'll have pointed chin. That is what is called as the Soto syndrome. Okay, right. So just one more time, let me just show you the question and then I'll move on to the next question. Yes, so this was the question. Right, so the question was, physical condition of child shown in photograph is seen in adrenal insufficiency, not at all, because they'll have weight loss. Pseudo hypoparathyroidism, right? They'll not have this obese look. They'll have this short fourth and fifth metacarpal. Soto syndrome, they'll have long narrow face. They'll not have this obese looking face. So this is a case of the Prader-Willi syndrome, right? Next. Now we will move on to the next question. Yes. The triad shown in the photograph is useful in the diagnosis of, what is a triad? It is your Whipple's triad. The triad is the Whipple's triad. So what is there in this Whipple's triad? What is given? Low plasma glucose, signs and symptoms of hypoglycemia, resolution of the symptoms once glucose level rises. Resolution of the symptoms once the glucose level rises. What is this suggestive of? Avinash, is it glucagonoma, Avinash? In glucagonoma, you will have high glucose levels or low glucose levels, right? Very good, Himanshu, and as well as Vaibhav. The answer to this question is the insulinoma. The answer to this question is the insulinoma. Okay, right. So in insulinoma, there is excessive production of the insulin because it's a tumor of the beta cells. It's an excessive production of the insulin. Now, because of excessive production of the insulin, what will happen to the glucose levels? The glucose levels will be reduced. Once the glucose levels are reduced, you have signs and symptoms of hypoglycemia. Right? You will have signs and symptoms of hypoglycemia. So once there are signs and symptoms of hypoglycemia, once you give some sugar, right? So once you give some sugar to the individual, there will be reduction of the symptoms. There will be reduction of the symptoms. So this particular triad, whatever is there, this is called as Whipple's triad. This is called as Whipple's triad. Okay. And where do you have this particular Whipple's triad? You will have that in patients with the insulinoma. You will have that particular Whipple's triad in case of insulinoma. Okay. Right. So Whipple's triad is different and Whipple's disease is different. Right. Can anyone tell me what is this Whipple's disease? Yes. Can anyone tell me what is this Whipple's disease and what is the organism which is responsible for this Whipple's disease? So the organism which is responsible for this particular Whipple's disease is, the name itself tells you, that is Tropharema. Vaibhav, it is not vasculitis, yeah? Yeah. So it is the Tropharema Whippleyi. Right? And in these, it is a malabsorption disorder. Right? It is a malabsorption syndrome. Where exactly will be the site of the pathology? That is within the small gut. Right? Small gut. Okay? Right. Yeah, it's a bacterial infection. So that Whipple's triad is different and Whipple's disease is different. Whipple's triad is different and Whipple's disease is different. Okay, right. Now coming back to the question on the insulinoma. Now, can anyone tell me how do you diagnose insulinoma? Right. So we will come back to our Whipple's triad. How do you diagnose insulinoma? Can anyone tell me? Right. So the way by which you can diagnose this particular insulinoma is right. Very good, Avinash. Excellent. So the diagnosis of the insulinoma, it is done by the prolonged fasting glucose. You have to check the prolonged fasting insulin and as well as the C peptide levels. So what you have to make the individual to do? You have to make the individual to do a prolonged fasting up to 72 hours. Up to 72 hours. Or, right, it need not be up to 72 hours, or whenever the glucose levels are less than 40 milligrams per deciliter. At the same time, check the insulin levels. Right, at the same time, check the insulin levels, and at the same time, check the C peptide levels as well. Right, now you take in a normal individual. In normal individual, when the glucose levels are reduced, right, in a normal individual, when the glucose levels are reduced, what will happen to the insulin? Even the insulin levels are also reduced. Right, what will happen to the insulin level? Even the insulin levels are also reduced. When the glucose level is reduced, the insulin level is also reduced. That is what should happen normally as a part of the compensatory mechanism. The insulin production should stop. But in insulinoma, what happens? In spite, right, in spite the glucose levels are low, the insulin levels are still high. Okay, so in insulinoma, right, in insulinoma, in spite the glucose levels are low, the insulin levels, they are still high. That is how you can diagnose this particular insulinoma. Now, right, if you go back to our discussion on diabetes mellitus, what did I teach you? So I have taught you that, right, I have taught you that this particular insulin, whatever is being produced from the beta cells, the beta cells, they will produce the pre-pro insulin, which is finally converted into insulin. Right, which is finally converted into the insulin. The pre-pro insulin is converted into insulin. Now, in between, what will be released? There will be release of C peptide. Right, there will be release of the C peptide. Okay, so now what is happening to your C peptide levels in insulinoma? Even the C peptide levels are also elevated. So if 1 unit of endogenous insulin, if it is released, right, 1 unit of endogenous insulin, if it is released, there will be 1 molecule of C peptide. Right, there will be 1 molecule of the C peptide. Okay, so please remember that 1 unit of insulin, if it is released, there will be 1 molecule of the C peptide also. Okay, so both of them, they're endogenous insulin. But again, please remember another point, another important point. What is that? Exogenous insulin will not have C peptide. If the insulin in the individual is there, which is from exogenous source, exogenous insulin will not have the C peptide again. That is another important, very important point that you need to remember. Okay, right. No, I am not in Goa, Avinash. It's a virtual background. Huh? It gives me a feel that I'm in Goa, but I'm not in Goa. Okay, right. Okay, so you see the next question. True about the condition shown in the photograph. Seen mostly in females, prevalence decreases up to 40 years of age, no genetic predisposition, smoking is a risk factor. Very good, Avinash. Excellent. So the answer is smoking is a, now what is this? Obesity. What is this? It is obesity. So for the obesity to occur, right? For the obesity to occur, smoking is one of the risk factor, right? Smoking is one of the risk factor for the development of this particular obesity. Okay. So there is nothing much in this question. Yes, this is one of the interesting question, and let me discuss much on this particular question. Disease shown in photograph is not characterized by hyponatremia, hyperkalemia, hypotension, metabolic alkalosis. Yeah, so this is the last question. Right, this is the last question for the day. Right, so very good, Avinash, and as well as Yadav. The answer is metabolic alkalosis. The answer is metabolic alkalosis. Now, can anyone tell me what is the diagnosis of this image first of all? Yes, any one of you? Please tell the diagnosis. Please tell the diagnosis. Yes. So diagnosis, it is nothing but Addison's. Very good, Avinash. Excellent. It is Addison's disease. So what is that you are making out? There is presence of hyperpigmentation on the elbow, right? And there is also hyperpigmentation on the gums, right? And you are also able to make out the hyperpigmentation over the palms. So now alabaster skin, yes, Soumya, alabaster skin, you will see that in case of secondary adrenocortical insufficiency, not in case of the Addison's. Your Addison's is primary adrenocortical insufficiency. Right? Your Addison's is primary adrenocortical insufficiency. Now in Addison's, all the hormones, right? Which all hormones? There will be decrease in your corticosteroids. Right? And there will be also decrease in mineralocorticoids. Okay? And there will be also decrease in weak sex hormones. Right? There will be also decrease in weak sex hormones. Okay. everything will be decreased. Now, when your mineralocorticoids are reduced, what does these mineralocorticoids do? These mineralocorticoids, MC stands for mineralocorticoids. They will cause sodium retention. They will cause potassium excretion. They will cause the H plus ion excretion. Okay. Right. So that is what is the action of the mineralocorticoids. There will be increase in sodium, decrease in potassium, and decrease in H plus if mineralocorticoids are present. But right, but in Addison's, mineralocorticoids are absent. So when mineralocorticoids are absent, what will happen to your sodium? It is not retained. It will be decreased. Potassium will not be excreted. It will be increased. H plus ion will not be excreted. That will be increased. So this will result in hyponatremia, hypokalemia, and acidosis. Okay, so now we will go back to the question now. We will go back to the question. So there should be hyponatremia, there should be hypokalemia, and there should be acidosis. Now, you see, hyponatremia will be there, hyperkalemia will be there, hypotension also will be there because corticosteroids are absent. But metabolic alkalosis will not be there. What they will have is metabolic acidosis. Right? Metabolic alkalosis will not be there, but there will be metabolic acidosis. Okay, right. So this is about the question related to your Addison's and their respective electrolyte abnormalities. Okay, so with this, I will wind up the today's session on the image-based questions on endocrinology. I will continue tomorrow also. Tomorrow also, same timing, 10:30 p.m. on the same platform. We will be discussing part 2, image-based questions on the endocrinology.